introduce Waseem Hawa. So Waseem, I will not tell you the gossip except to say he's a dear friend. And I miss him terribly at Lenter here, but he's now gone on to greater and wonderful things. So he is the principal psychologist at Valkenberg from 2019. And that includes convening the intern psychology program for the Southwestern substructure. He's also, I think, currently in the role as acting deputy director of medical support for the hospital since April 2021. And he's also the convener of the Child Criminal Capacity Assessment Service for the hospital. He's the current chair of the Division of Psychotherapy. So he completed his master's in clinical psychology in 2010 at UWC. He completed his internship here with us at Lenter here. So he's a child of ours, and we will take full credit for him. He did his community service with us as well. And then he went on to the Department of Correctional Services in Worcester, where he did absolutely amazing things. Before coming back to us at Lenter here as the psychologist at Male Acute. His special interest includes substance use, psychosis, and neuropsychology. Waseem, I hand over to you.
Thank you so much, Nasira. I've been at Lenter here on 3 separate occasions, which includes being an intern, a ComServ, and then also being a permanent member of staff. And I remember the 3rd time when I came back, I told Sister Salam, I'm Lenter here's athlete's foot. No matter how hard they try to get rid of me, I keep up ending back. So with that, I'm going to just start with my presentation, and let's begin. There we go. See, I'm fond of transitions. Can everybody see the curtains opening and us looking at the title page, just to confirm?
Yes, thanks.
So what I'm looking at today is the collaborative counseling strategy and the review of Valkenberg in the strategy. And it's a strategy between the University of the Western Cape and the Departments of Health. And there are many, many role players here, but in terms of my title slide, I look at our own hospital. I look at a snippet from the Student Learning Center at Vanguard, where a lot of the meetings took place. Unfortunately, all other pictures had images of patients in it, so Poppy made that I couldn't include that. And then, of course, our beloved UCT, where I also had the opportunity to study. So in terms of contents, I'm really trying to look at what is social responsibility, to describe what the collaborative counseling strategy is, how did this project come about, why is Valkenberg involved in it, what have been the challenges that we faced in this project, and the question that I continue to sit with, which is this project an act of social responsiveness, or is it business as usual? And I think it would be really wonderful if at the end of the presentation, we as a forum can reflect on that. And then also looking at concluding comments and a space for questions. So what is social responsibility? And thank you, Nasira, for sending me your documents. Yesterday, I was urgently pulling this presentation together. As you can see, I love my transitions. So the concept of social responsiveness can broadly describe a person's obligation, just moving this about, to the welfare of others, or it can be applied in more specific contexts. It's a commitment to contribute to community or country in a way that makes the quality of life environment better for those around them. So the department does have an established social responsiveness committee, of which Nasira and Beatrice are co-chairs, and it's focused on innovative partnerships between UCT academics and external stakeholders, which does include government at all levels, local communities, national and international social movements, and continent-wide organizations. So our committee has done quite a lot of work, and I think in some of the documents that I was reviewing and the information that Nasira has given us is that the work seems to have happened, but there may not, a lot of it couldn't be hemmed to some sort of formal project. So the committee's engagements take varied forms, which include the following, which is research activities, engagement with policy development, public commentary on development issues and strategies, social outreach activities, which is one that we flag in terms of this project, programs to empower external constituencies, the improvement of the relevance of the curriculum, also something for us to consider in terms of the collaborative strategy, and also providing opportunities for lifelong learning. So the reason, so I'm not a member of the Social Responsiveness Committee, but I felt it was important to think about what its mandate is and what its activities are, because it's been part of my process in terms of trying to understand the collaborative counseling strategy. And so I'm trying to establish and determine, does this constitute an act of social responsiveness? So now the big question is, what is the collaborative counseling strategy? So currently it's a joint venture between the University of Cape Town and the Western Cape Department of Health. It's looking at the Faculty of Health Sciences and the Department of Social Development, which is in the Faculty of Humanities. Currently, it involves the deployment of 6-year medical students, a pair who are in the psychiatric block, and a second-year social work student to Vanguard Community Health Centers. These students are trained and supervised to provide a brief counseling intervention, which is 3 sessions to treat maternal depression and anxiety, therefore tapping into the importance of the first 1,000 days. So thinking from conception to that first 1,000 days of life. So the students are trained through the use of a manual developed by Professor Catherine Sorstar, Professor Bronwyn Myers, and Dr. Claire van der Westhuizen, and is an adaptation of Project Mine. The actual training of the medical students is conducted by Naima Parker, who is a member of our department, in their first week of the psychiatric block. So out of the 4 weeks, week 1 is where the training occurs and the students go through the manual. There's various activities to have build those counseling skills and to practice. And then in weeks 2, 3, and 4, they then move into the site and actually implement the intervention. So the intervention is devised to equip the students with the skills to offer brief evidence-based intervention. And I think when we look at the time pressures that we have within government and the dearth of resources, and by resources we mean people or clinicians, the obvious way to move is to look at providing evidence-based brief interventions. So it may be brief solution-focused therapy, it might be supportive therapy, but finding ways that will allow us to attending to our ever-increasing waiting list. So it aims to support a pregnant mother with symptoms of depression and anxiety, and is also recently aimed at flagging substance use. It provides the students with basic counseling and coping skills. And so the aforementioned counseling skills assist to guide a mother through problem solving in an empathic way. And if I reflect on my internship years where I was deployed to Lentegeur Clinic, I found that using a problem solving approach with patients was very useful. Often there was an immediate crisis that needed to be attended to. And one of the things that comes out of this process is you're actually doing a skills transfer with the patient so that they're able to apply those skills in a variety of contexts. And I recall even with more medium-term patients, less than 4 or 5 sessions, seeing how they apply those skills to different problems really showed the value of skills transfer with our clientele. And just to give a snippet to an example of a session, so if you look at session 1, it includes a brief assessment for depression and anxiety. It involves psychoeducation, which is sharing information about symptoms, understanding the possible cause of these symptoms and what to do to feel better. And I think that's very complex when we think of society. When I speak to our intern psychologists and I often taught on substance use, I reflect on what is it that we do with middle income when we are feeling unhappy about something or we are feeling a bit overloaded. And I shared I'm a particular fan of science fiction, and I am happy with both Star Wars and Star Trek. I feel one can hold both models in your head. And whenever I felt a bit off, I would go to Cape Gate Cinema, where they have a 3D, whatever, IMAX projector, and watch a movie by myself, which is something I quite enjoyed. But that entire exercise would cost 300 to 400 Rand in terms of the tickets, the drive, the petrol. There's a cost involved. And what do people who are living on minimal income do in terms of trying to ameliorate their own distress? And so I think that from a substance perspective, a lot of my understanding is formed of it is the way of release, and it's often the cheapest way to relieve things. So it's just about explaining some of the symptoms that people might have and looking at how they're currently trying to feel better and what other ways they could be feeling better. It also introduces the patient to problem-solving therapy. So everyone has stress and worries, and we know it varies in terms of your level of income and internal and external resources, but it is an everyday part of life. And sometimes these problems feel like they cannot be solved. And this is what we're teaching the interns to teach the patients. And it can make one feel overwhelmed and helpless. And the program really teaches you the skills to cope, or tries to cope with the problems, and helps you take control of them. Getting control back of your problems will help you feel better and less sad or depressed. We are real about the situation. You know, there are certain problems and issues that might not be solvable, but where one can make shifts, we should encourage those shifts. And so it's conduct problem-solving sessions. So it's an opportunity to practice the problem-solving steps. I'm not going into session 2 and 3, but I wanted to demonstrate how structured the actual sessions are in terms of what the medical students and the social work student is doing with the patients that are being referred to them. Something that I really didn't have time to scan, I was trying to first find the document, is the wonderful referral form which was made by Vanguard Clinic. And so the patients are identified in the MOU by the clinical nursing practitioners. I think there's an echo. And then they are referred to these students. So session structure, just to give a little sense of what the structure looks like. It's providing an introduction, describing what happens in session 1, conducting an assessment, which is really helped through the referral form, which is essentially a tick sheet that allows you to score where the person is at, providing psychoeducation, describing the problem-solving method, conduct a problem-solving session, and then a wrap-up. So very much we see a orientation, we call it testing out, or we used to call it out in social work, which is setting the frame or setting the boundaries, then getting into the work of it, but also finally wrapping up the space. So it follows the course of a normal therapeutic session. So a collaborative care model is utilized. The case manager is the student, is trained and supervised on a weekly basis on the intervention. Virtual supervision is offered by a psychologist, which is Kathy Aaron, or at least it's made available. We have a really fantastic intern, Isabel Buick, who is based at the clinic. She's an intern psychologist and provides peer support to the students, which includes a mix of logistics in terms of how to navigate the space, and also sharing of our own clinical knowledge. And I really want to take this opportunity to really applaud the intern in terms of the extra steps that she's taken in terms of doing psychoeducation talks with the social work student who's currently there in the waiting room in order to address the issue of stigma, holding little discussions in the morning with the students in terms of the types of cases that they've been referred, as well as debriefing thereafter, just checking and flagging how they're feeling, and also looking at the continuity of care. Because in a session of this kind, something much bigger might emerge that requires intervention from a different specialist or from psychology itself. And so it cannot just be that the sessions just end and there's no further process that occurs. And that space is really being held by our intern. So as I mentioned, the referrals are identified in the MOU by the OPM and a team, Sister Wilhelmina Dyers. I hope she's with us here today. And then we also receive guidance, leadership and support by Prof. Namane and Sister Sham Naidu, really been instrumental in helping us to enter into the space. So how did this project come about? That's the big question for me. So during 2020, South Africa and the Western Cape, as we all know, was hard hit by the COVID-19 pandemic. And the medical crisis served to, in my opinion, only exacerbate an existing mental health crisis. I think we were already in trouble before the pandemic, and what the pandemic has done, we call it the mental health wave, has just highlighted and foregrounded the psychological crises and mental health crises that many people are facing at all levels of society. So a need for more resources for mental health services was clear. This call was made repeatedly for multiple spaces. And at this point, I do want to emphasize, I felt like I came in 1/3 of the way into the movie, which is, there was quite a lot of discussion that happened, which I rightfully wasn't privy to, but became aware at a certain point of this project. And then identify what my role would be, in which I'll discuss a little bit later. So this discussion was happening, and UCT faculty members answered the call in terms of providing resources. And an idea took hold. How could students in the caring professions provide greater support to the management of the mental health crisis? And Dr. Karen Big, I hope I got her statement right, but it really stuck with me and I really like it, which is it's learning through serving and serving in learning. And I think it's such a beautiful way to describe the caring professions move forward. You know, at one stage, students were recalled from the site visits based on the idea of the risk and de-escalation of services. But there's been a counter discussion or a counter argument made, and one which I fully support, which is that students are being trained to deliver health services. And in the context of a pandemic, health services still need to occur. And although we should take every measure to protect the students, ultimately they are going to operate in that space at some point. So a conversation began or continued between UCT and DOH at senior management level. And that conversation led to several internal discussions by the stakeholders to discuss the collaboration and what form it should take. And so there were discussions here at Valkenberg within our teams. I know there was discussions at district level, that there were discussions at Vanguard Clinic. At this stage, everybody is thinking and talking with their own teams in terms of what should we be trying to do. And the internal stakeholder discussions then resulted in a series of theory of change workshops, which is different from the more recent ones which occurred within the catchment area. And those discussions took place, to my knowledge, at Valkenberg and also at Lentegeur. So the workshops were facilitated by Professors Catherine Sorsdahl and Craig Lunt. It included stakeholders from the university, Valkenberg, and the district, and it was really an incredible experience for me, who is very new to the Southern Western substructure. Ek is 'n Lid. I know the Boerland well. I understood the Northern Tygerberg substructure well and knew who the individuals were in that space. but it was still coming to grips with Southern and Western, which is made up of many, many, many different parts. And so being in that room for me was also a personal opportunity to actually get to put names to faces, names that I've heard, but I'm not really sure who the person is. And in that discussion, which included representatives from coalface to senior management, which is also an amazing feat, it was decided that a pilot project would be launched. And in the Southern Western substructure, Vanguard Community Health Center was identified as the pilot site for our substructure. And this site was part of the process early on and played a critical role in initiating the collaboration. It also has an MOU which speaks to where the project went. So over the course of these workshops, 3 key areas which could be addressed were identified, which include substances, the first 1,000 days in HIV, and ultimately the first 1,000 days was identified as the key priority area for the pilot project. So maternal depression and anxiety was targeted. Substances were flagged from the beginning and has also been an area of focus with expectant mothers. The idea is we start with something small, you know, even if I look, and that's something I truly believe in, is you pilot something first so that you can see where the glitches are. And there are always going to be glitches in the launching of any project. Even in our mass vaccination rollout at Valkenberg, we first piloted with 1 ward to pick up, well, what's working, what's not working, who are the people that we need to identify. So if this project works, then it could be expanded to the original vision. And I think there is an original vision of a much more comprehensive collaboration, which could address the length and breadth of the mental health crisis. So what is Valkenberg's role in this project? Why are we here? And how did I get here? So at one particular meeting discussing the potential collaboration, I struggled with a major crisis. And this was truly a major issue for me, which is how do I prevent the cold milk that was available on the day from cooling down my hot tea? Tea should be hot. So it was a difficult moment, and it was in this difficult moment when it was brought to my attention that I would be expected to play an active role in the project. The big question is, why would the principal psychologist of Valkenberg play an active role in a project that was based in the community and focused on an area that does not directly affect VBH? We admit 1 to 2 pregnant mothers annually into the hospital. So I sat quizzically wondering what I would be doing within this space. But first, just so that you know, the crisis of the cold tea was solved. There was a microwave on hand and I was able to bring it back to an acceptable Indian temperature. So the answer as to why I was asked to play the role is because I'm dashingly good looking. No, the real answer is comprised of 3 reasons. So firstly, as a joint appointee, it was hoped that I could serve as the bridge between the university and the pilot site. Secondly, I do supervise the intern psychologist attached to the clinic for the year, and she plays and was planned to play a critical role within the project. So the counseling intervention also does fall within the purview of psychology, as it does for many of the caring professions, but it was part of our ambit. As both the intern and I are employed by Falcon, by default, Valkenberg's role and my own is one and the same. We are hopefully the bridge. Sometimes that bridge is wobbly, but we are hoping to be able to bring the university and the departments of health, specifically the clinic, together. So what does this role entail? I'm not fully clear yet, but it does include a great deal of coordination, documentation. Yes, a study is needed. The 3 stars is the name of the person that I shan't name. I'm referring to. Copious amounts of emails and far too many cups of tea and muffins. But essentially it's about trying to bring things together. And so there have been many challenges in this project. Right from the beginning, it started last year already when the discussions began. And several things come to mind for me in terms of the challenges that we face. And so the first and most obvious challenge has been the chaos of the pandemic. It's led to a stop-start process. So the escalation and de-escalation in services, trying to establish whether students should be present or not, setting up so that we could move from face-to-face to virtual meetings. All of this was very complex, and right from the beginning, there were several delays, even in terms of doing the site visits at both Vanguard Community Clinical Center and also the site in Mitchell's Plain. So we are already a healthcare system that was under strain, and I think launching any new project within that context is going to be difficult. I don't think there's one person in this forum or within our department who isn't extremely busy with very tight schedules, attending to patients, whether it be directly at coalface, whether it be administratively at different levels. Nobody, from what I've observed, nobody can tell me people aren't working. And one of the things we also have to look at is communication with so many stakeholders. And you know, this has also been an issue for me. It's been a difficult task just in terms of remembering everybody that should be included in a very large system, because there are so many different role players. And so one of the things that this has been a learning curve for me is trying to improve and refine that process so that everybody's on the same page. I think also, you know, emails have made life very easy, but they've also made information overwhelming. I often tell individuals, if I just step out of my office for a few seconds and I saw your email a minute or two ago, the amount of communications that's coming through as it is for everybody, I would actually have to go and look for it. And so does something also get lost in electronic translation? We all have multiple roles and duties, and that's the case for each and every person involved here. And so there is your primary work that you're doing or your primary portfolio. Now you're also involved in launching a project and juggling that and managing that so that you are attending to the work that you were originally supposed to do plus the new project is also a difficult process, and one has to be able to find the balance. And then we also look at the stigma around mental health. So just if we look at the uptake at the moment, and I think that's also been complicated by the stop-start nature of the project, the stigma of seeing a psychologist or going for counseling, and that's covered in the manual, is something that also prevents people from accessing resources when needed. Which brings me to almost the conclusion of my presentation, which is, does the collaborative counseling strategy represent social responsiveness, or is it business as usual? So the project represents a collaboration between UCT and the Department of Health. And the fact that the university has adapted its training to address the mental health crisis could constitute an act of social responsivity. The case could be made of the fact that so much effort has been put in by all the stakeholders in improving the quality of life of the individuals and the community by extension, that it really is that. The fact that the university is deploying its students into a different space, even where they're still couched in training, further strengthens the case. That being said, all the stakeholders are either in the field of training students in the caring profession or within the DOH ecosystem. So would this project, as wonderful as what may be, not simply be business as usual? Are we not expected to adapt and evolve our services in response to whatever crisis we're facing? So even though we may be innovative in the way that we're dealing with things, is it something different? So in terms of my concluding comments, so the collaborative counseling project continues in its gestation. I again borrow from Dr. Begg. We seem to be reaching the end of the first trimester. There have been many scares along the way. At one point, it seemed as if we would lose the project, but it seems to be back on the right developmental track. Whether it constitutes an act of social responsivity is, however, for this forum to discuss and reflect and think about. So before I end and open the panel for discussion, I really would like to thank the following key players in the launch of the project, which is Prof. Masedi Namani, who I hope is sitting here today, Sister Sham Naidu, and Sister Wilhelmina Dyers, who form part of the team at Vanguard CHC and the entire team itself, Prof. Stein, Dr. Karen Begg, Dr. Tracy Naledi, Prof. Catherine Sorsdal, Prof. Bronwyn Myers, who was part of the original manual that's been used, Dr. Claire van der Westhuizen, Prof. Kricklund, Ms. Naima Parker, Dr. Mariam Kajika. This is the email list and only the beginning of it. Ms. Alexa Kroon-Canning, who is the social work supervisor, Ms. Fatima Williams, who was once my supervisor when I was a social work student, a very difficult student, if she remembers. Hope she's here today. Ms. Jackie Stewart, who took over from Fatima Williams, Kathy Aaron and Isabel Buick, and also the 6th-year medical students and our social work students. And this morning I realized I forgot to add Carol's name to the list as well.
Yes,
so just to add that.
Bridget, can you just mute yourself, please? Bridget van Dijk. Sandra, are you able to mute her? Sorry, Waseem.
No, it's okay. I always like to eavesdrop, so it's fine. Gossiping is part of my culture. So we move on. So just really to thank each and every person who was at the Theory of Change workshops, and there were a lot of role players there, and I would be lying if I could say I could recall each and every person who was in that space. Really thank you to helping develop this pilot project. And that brings me to the questions part. So I'm hoping the forum will now speak. I'm going to end sharing, if I know how to do that more. Just see. How does can one pause share? Would that work?
No, there should be a button that just says stop sharing. Right at the top, maybe.
Just mute, stop video, participants, chat, new share. Ah, there we go, stop sharing. There we go. So that's my little presentation for today. And now it's for the team to discuss.
Well, let's get Nasira back. And I think while Nasira comes back to lead the discussion, I think we can certainly start with a round of electronic applause to Waseem. So here it comes, Waseem. Everyone else, please join in giving him a good round of applause and for making us think. And Nasira, I'm happy to join the discussion, but I'll hand back to you to lead the discussions.
Thanks, Waseem, and very well done, I think, on the presentation, but also on this wonderful counselling strategy initiative, which I'm so glad you've raised it and raised the issue of is this yeah. I'm lost for words even. Is this social responsiveness or is it business as usual? I think is the big question. For me, I would almost say it's both. It can be both. And I'm wondering.
Such a psychologist answer, Nasira. Hold the ambiguity.
I think we'd be keen to get others to join as well. I mean, just a very pragmatic comment, Waseem, is that anybody who is joint staff at UCT, one of the key performance areas of our job descriptions is in fact social responsiveness activities. And so from a kind of an employment point of view, we all have a duty as UCT staff, as university staff, to do teaching, administration, clinical care, participate or facilitate research, and do socially responsive activities. And so clearly what you're doing is therefore, in a way, part of your job. And I think to take it slightly further, just to kind of help get the conversation started, I think part of our duty as healthcare providers and professionals in our country is everything we do should actually be socially responsive. So there shouldn't be a separate box for being socially responsive. I think everything we do should be through the eyes of being socially responsive. In other words, we should teach through the eyes of the needs of our communities. We should provide clinical services through the needs of our communities. We should do research through the needs of our communities, et cetera, et cetera. And so I know you've deliberately set it up as a dichotomy, but I think the philosophy should be everything, is because the other side of the coin is, I've heard people say psychiatry, mental health problems are such a social need, so anything and everything we do in psychiatry is therefore socially responsive. But it may not always be the case. So I think we do need to be very critical and reflective to say, is what I'm doing truly in response to the needs of the communities we serve? There's lots of kinds of research that I would argue is for the benefit of the researcher, or for the benefit of getting the next grant, or for the benefit of getting a paper, but not necessarily for the benefit of the communities we serve. So I hope that's sufficiently provocative to get people joining in. And the other comment just from me is, in the Social Responsiveness Committee, we certainly support the overall philosophy of social responsiveness, i.e. in response to the needs of the communities we serve. But there's also a component that we have 4 main stakeholder groups. So the one is government, so working in collaboration with government, as this project you're describing is. We also want to do social responsive work with our other professional colleagues. So that's why we do CPD kinds of activities, training, support, etc. We also want to work with other non-profit organizations, user carer organizations, like Cape Mental Health, like Autism South Africa, like whatever these organizations. And I think we also have an important role in relation to working with the general public through communication, participation, etc. So you can see it's like almost like concentric circles that are all things we should think, how does my work contribute to social responsiveness at one or more of these sorts of levels? So maybe with that kind of background story, the one thing I was a little bit part of some of these theory of change workshops, the question I keep asking is, are we truly doing what is in response to the needs of the communities? And my bugbear is, to what extent are the recipients of this project of our care active participants in the design, the development, and the evaluation of this process? Because we may have great ideas about this is the perfect solution to the social challenge, but the risk is we often make decisions on behalf of the communities we serve rather than to develop them in partnership and to keep asking our families, patients, users, carers, whether we are actually hitting the spot. So I'm going to pause. Maybe you can start with a response, Waseem and Nasira, and then I hope others are sufficiently stimulated to comment too.
I'm going to latch onto the last thing that well, 2 things really to speak about. Firstly, about whether the projects that we launched are the intention around research and all the processes that's involved with that and grants, etc. And then the second thing I would also like to latch onto is the patient a co-collaborator to whatever it is that we're doing? I think in the theory of change workshops, there may have been representatives from mental health user groups. I can't recall, but I would have to say, actually, no. I don't think, and I don't think we're doing that in any spaces where we are actually having representatives from the service group indicating what they feel that they need. And even if I look at our discussion at Valkenberg, what's really been happening in terms of the facility board, which is that there is a call to have a representative of a mental health user on the actual board of the hospital in order to articulate that voice. And I think if there was going to be a study, we would want to hear what was the experiences like of this project. Was there any value? Yeah, and you know, then one goes back to the research issue. I can quote Dr. Naledi's words on that day, which is, this isn't about research, this is about helping the situation. So we are not focusing on setting up a research project. We want to, if it's going to be research, it might be implementations, science, or it might be grounded theory that we're going to be utilizing. But the focus at this point is, what can we do as UCT and the department to assist you with the crisis that is being communicated? So I would say, I think that this process has not been research-led. It hasn't been about grants and proposals, even though I think there is space for that, because we do want to document what we're doing in an empirical fashion. But I think it's been about what we can do differently. Any other hands? Naima? You're on mute, Naima.
Hi there. Yes, yes. I was just trying to unmute myself. Okay. Thanks so much, firstly, Waseem, for just a very comprehensive presentation in your trademark colorful style. But thanks for capturing so much of the information. And I just also want to say, just to really emphasize the role Waseem has played from a logistical perspective. There really has been so much communication, especially with all the stakeholders at the clinic and just with everyone involved. So kind of just providing that reach, so to say, that you mentioned. I think I just maybe wanted to touch on what you were speaking about now. And absolutely, I mean, I think the focus has been about, providing a service, and in terms of establishing where that need is, we thought of starting, or the thought was to start with Vanguard. There's also, a lot of support available for the students there, etc. But just in terms of the patient's experiences, I think just what we are working on is that we, of course, would want to document something around this pilot project. And so we are working on, just a very brief study, at least to just, determine the feasibility, the effectiveness, efficacy, etc. And one of those, so what we would look at is 3 areas, and that would be sort of checking in around, acceptability and mental health literacy, etc., with students, first of all. And then secondly, with the patients who are accessing this particular counselling strategy as well. And then on a larger scale is, the broader stakeholders that are involved, particularly the clinic staff at the MOU, etc. So myself and Waseem's going to be involved as well. And Kat Sorsdal has really been instrumental in just helping us with putting together an ethics proposal at the moment. And so it's really just, I'm thinking about it in terms of what you had raised, Beatrice and Waseem, around patient experiences and them having some, part to play in this, of course. And one of those is to hear what the experiences have been as we go through with this pilot project. And then I see Tessa asked a question about how many patients have been counselled so far. I don't have the stats in front of me. Waseem, I'm not sure if you want to touch on that, or... Oh, you're still on mute? You're still on mute.
So I don't have the exact figures on hand. I don't think that it's a large amount, because the project is really still in its infancy. So we're still building up to something. And then when we seem to have reached a point where the project was going to really move, then we had a stop because of the 3rd wave. And so it's about restarting again. I definitely think we've reached at least 8 to 10 people. That's a definite. It could be more than that, but I wouldn't want to speculate until I've seen those figures again.
Yeah, just to add that so far, 2 blocks of students have gone through the full sort of cycle of the month at Vanguard, and then the 60 students were taken off the clinical platform. So that's why we've had a elapsed at the moment, and it's been put on hold. And also then just to say, of course, especially with the first block of students, that they then encountered a lot of the practical, teething, so to say, issues around things like screenings, referrals, patients knowing what to expect, etc. And so a lot of it was also around dealing with those aspects of patients coming for the sessions, etc. So we do hope to have more flow, I think, as we go along, particularly from this block onwards. Thanks so much.
No, that's great. And I think what you're doing is an example of what we might call a model demonstration project. You take an idea, you implement it in a small little way, and then you evaluate if this works, because if it works, you're using medical students, existing systems, then you know it's something that we can scale up. And then potentially the 2 students per block can become 180 students across the whole city or across the whole patch. So that's why these kind of model demonstration projects are really important. And in fact, Waseem, we're into false dichotomies in the discussion today. I would argue that it's a risk for us to say, is it research or is it clinical? And to comment on Tracy's statement, we should not forget that we also have an ethical and a social responsive duty to evaluate, to make sure this thing works. Otherwise, we might spend millions of time and all the limited time that we don't have implementing something that actually doesn't have a real impact to the people who need it. So I think, and apologies if you're getting me on my hobby horse, I think it's important that we remember that research can be a tool for empowerment of our local communities. We should move away from thinking research is something that happens in an ivory tower somewhere else, and that research is detached from the real needs of real people in real communities. So I'll mute myself again, Waseem, and hand back to you and Nasira. Any other comments, questions from anyone? Naima, is that you again, or is that still the same hand from before?
Oh, apologies, it's the same hand.
Okay.
Oh, no, thanks.
And I see you've had some lovely comments from Fatima Ismail, Waseem.
Yes, from Fatima. Yes. And thank you, Tessa, also, and to everybody here. And really, again, this is the work for this project. So many people have been involved and so many people have worked hard, and really the clinic has been quite incredible. And I've been to the clinic to see what's happening on the ground, and I was quite shocked when I saw Vanguard, because the size of it and the volumes of patients that are being seen, and the fact that the team has taken the time to say, well, we think this may have value, we would like to invest in this, to do that on top of what's already happening in terms of the workload, and the fact that it's become a vaccination site and they're still with us. I mean, for me, that's why I really feel should be thanked.
That's great, yeah. Nasira.
Yeah, I think this type of research, as you say, Petrus, it's really needed, but also wonderful because it's so practical. It's and I know that's where my niche is, more the practical applications of it, but just the joining of the research and the clinical knowledge. You know, it's we actually don't do enough of it, and I think this project is just an example of how the two can marry so beautifully.
Yeah. And I think, given that this is a social responsiveness talk, I think it's also an encouragement for all of you to be inspired by what Waseem found himself engaged in. You may have
just written much bigger.
No, that's good. You might not have sought it out, but you are working on something that truly is collaborative, with government, with other people. It's not just in your own little clinical patch thinking about the immediate needs of patients at Valkenberg. It really is something that might then have a bigger footprint. And I think all of us should think, how can I participate in what can be my contribution to social responsiveness? And we've talked about government, but maybe think in terms of if I just imagine working with the public, maybe think are there things you can do in terms of either talking on the radio or having a blog or engaging with the media or talks to general public and to schools and to all those have an impact in terms of our communities. John Parker, the very creative Lentegeer Spring project that they've done. I remember off the top of my head, Sean Bowman's opera. I mean, that's it's a creative way, but it has a major social impact to the general public because of what he's done. Or being on the boards of non-profit organizations or doing talks for them or teaching sessions for them or helping them advise about some of their challenges or struggles might be something, and thinking about working with other professionals, how do we liaise with other GPs or other sorts of professionals around mental health issues. And all of those can be incredibly rewarding activities for members of the department. And sometimes it's these extra things that we do on top of, as you say, the crazy busy schedules that actually make us feel, gosh, I'm really feeling as though I'm making a tiny little bit of a contribution to the community I'm trying to serve, rather than just to sit in my clinic seeing hundreds and hundreds of people, or just reviewing prescriptions, or just doing the core part of my task. So Nasira and Waseem, I want to leave the last 4 minutes to you. Maybe Waseem for a final comment, and then Nasira can just wrap up.
For me, thank you for this opportunity of being able to just give you a little bit of a snippet of what we are doing in terms of the work. And I always appreciate feedback and input from others. So even if it's not in this space, any continued discussion around the project and what we should be thinking about, I would welcome that. So you pop me an email, that's always the easiest.
Maybe don't send him an email now because he's frozen. He needs to go and warm up his milk first, I think. Nasira, maybe while Waseem is frozen, perhaps you can just wrap up and thank him in the meantime. Okay.
Sorry.
Waseem, are you back? Well, I think just on behalf of the Social Responsiveness Committee, I just want to say thank you so much for bringing such an interesting and innovative concept to us, I think, and just to get us all thinking of how to move forward in. Sorry, that's Waseem. Okay, take it. Bye-bye.